AKI is among the most common major adverse events that occur after cardiac surgery. Although the instance of cardiac surgery-associated AKI varies among AKI definitions, approximately 70 to 49% of patients undergoing cardiac surgery suffer from AKI, and 2 to 6% patients require renal replacement therapy.
What I'd like to tell you today is about the association between proton pump inhibitor and acute kidney injury after cardiac surgery.
Accumulating evidence has shown that the occurrence of cardiac surgery-associated AKI significantly affect post-operative mortality, length of hospital stay, and treatment-related costs. And patients requiring renal replacement therapy are more likely to progress to end-stage kidney disease. Proton pump inhibitors were recently found to be closely related to kidney damage. It is well known that episodes of acute interstitial nephritis are known to be increased with PPI exposure, and this increased acute interstitial nephritis instance has also been shown to increase chronic kidney disease risk as well. Additionally, recent cohort study data revealed that the instance of CKD was significantly higher among PPI users than non-users. However, relationship between PPI exposure and AKI has not been well elucidated yet. And for that reason, I set the aim of this study to investigate the association between PPI exposure and AKI after cardiac surgery. For study participants, two cohorts were involved. First cohort is the severance cardiac surgery cohort, which is tertiary hospital-based medical records. It included 6,555 patients aged 18 years or older who went through the cardiac surgery between 2011 and 2020. The second cohort is NHI senior cohort based on National Health Insurance Database. 2,939 of patients aged 60 years or older with having cardiac surgery done between 2004 and 2015 were included in here. And the preoperative PPI exposure was defined as a PPI prescription record within 3 weeks before cardiac surgery. Here is the flowchart of subjects in each cohort. After selecting those suitable for inclusion criteria and matching with propensity score, 895 of PPI exposed patients were matched with 2,685 of PPI non-exposed patients in severance cohort, and 700 matched with 1,383 non-exposed group in NHIS cohort. The primary outcome was AKI requiring dialysis, and the second outcome was in-hospital mortality, length of hospital stay, and length of ICU stay. And the following statistical analysis was used in the study. The following table includes the baseline characteristics of patients in severance cardiac surgery cohort. The mean age was 62 years, and 60.1% of patients were male. The median eGFR was 94.9. PPI-exposed patients were older and had a higher prevalence of hypertension, diabetes, and CKD than PPI non-exposed patients. The use of antiplatelet agents, AC inhibitor or ARB, and NSAIDs were more prevalent among the PPI-exposed than non-exposed group. Preoperative eGFR was lower in the PPI-exposed patient than PPI non-exposed patients. After propensity score matching, we can find the confounding variables were well balanced through the standard mean difference. And this table is for NHI senior cohort. The mean age was 72.4 years, and 58.7% of patients were male. Similar to the severance cardiac surgery cohort, PPI-exposed patients were older and had a higher prevalence of comorbidity than non-exposed patients. Antiplatelet agents and NSAIDs were more commonly used among PPI-exposed than PPI non-exposed patients. You can see this cohort is also well balanced after propensity score matching. This table shows clinical outcomes according to PPI exposure in propensity score matched cohort. Among the severance cardiac surgery cohort, 3.8% counting about 135 patients developed postoperative AKI dialysis. AKI dialysis and in-hospital mortality were more common among PPI-exposed patients than PPI non-exposed patients. The median hospital and ICU stay duration were also significantly longer in PPI-exposed group than the PPI non-exposed group. NHIS senior cohort showed the similar result. Conditional logistic regression model revealed the significant association between PPI exposure and AKI dialysis in both cohorts. This association was maintained even after adjusting the confounding factors. A similar relationship was also noted for in-hospital mortality. When we evaluated the association between H2 blocker exposure and AKI dialysis as a negative control, there was no significant correlation between these two groups. We performed additional analysis to identify whether the effect of PPI exposure on AKI dialysis was mediated through acute interstitial nephritis, which is represented by sterile pyuria. A significant association between PPI exposure and AKI dialysis was found in patients with sterile pyuria, but such a relationship was not found among PPI exposed patients without sterile pyuria. Let me briefly summarize. The incidence of AKI was significantly higher among PPI exposed than PPI non-exposed patients. PPI exposure was associated with an increased risk of AKI dialysis compared with non-exposure, and the association between PPI exposure and AKI could mediate interstitial nephritis.
Based on this study, we can conclude that proton pump inhibitor could be considered as modifiable risk factor for postoperative acute kidney injury. Thank you for your attention.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.